Dr. Rijju?
Yes, Supriya, can you share the slide, please?
Yeah.
Just a moment, sir.
I think my screen sharing is disabled.
Okay. Thank you, ma'am. Welcome back to another session. Thank you, John. So once again, let me formally introduce our faculty, Dr. Vineeṭha Rijju, currently specialist trained in palliative care, they're working with medical oncology department at Lakeshore Hospital, Cochin. He has completed the training in IPM Calicut and Cardiff University and was working with Aster Hospitals, Calicut and Kochi. It's an expertise in integrating palliative care in oncology. He is an MD Community Medicine from Amrita Institute of Medical Science, Kochi. So over to you, ma'am, for the second session on gastrointestinal symptoms.
Thank you, Arjun. So, good evening, everybody, and let's start. I'll just try to share my screen. Yeah. So, hi, everybody. So, we did have a session on gastrointestinal symptoms last day. We were talking about nausea and vomiting. And we did also have a case scenario to help us out a little more to understand about that. And today, I will be going through constipation and intestinal obstruction. Okay? So before I move on to constipation, constipation is one symptom I think all of us have been dealing with our patients, and we have been prescribing them laxatives, right? So what are the common laxatives that you use in your practice? Can I have the chat box? Yes, you may please type in the chat box. Which are the usual ones that you do prescribe? Yes, we have lots of responses here. Yes, Sheila says bisacodyl, Asra says lactulose, and then we have cremapin. A lot of you all say cremapin. Yes, Dr. Ruhi says Dalcola suppository, lactulose. Yes, Rahul says cremapin again. Nishan says lactulose, and again, enema is also used in our practice. And yes, we also go for PEG, polyethylene glycol. Yes, soap and water enema. Yes, so all of you, thank you so much for all those responses. And all of us have been prescribing laxatives, and it is just that this class over here is just to let you know on, again, how to choose laxatives and which will act best for your patients. So in this class, I will be dealing with the definition of constipation, and we will be going through the symptoms and how to manage constipation. Okay? So what is constipation? So what is constipation? So it can be anything, right? Your patients come to you and tell that, doctor, I'm constipated. Now, what are we talking about? Is the patient telling you that normally he has his bowels which open like probably thrice a day, and now it is only like once a day? Or is he telling you that for 3 days almost he has not passed stools? So we need to know definitely, or is it just that, he is passing stools, but it is not satisfactory? It can be any of these, right? When the patient tells you that he or she is constipated, it can be any of this. So it is very important for us to know what exactly is he talking about. So constipation, it can be difficult or painful defecation and is associated with infrequent bowel evacuations and heart cases. Right? So this can be the definition of constipation. And what is very important to us, I mean, you've been asking your patient, how is your bowel movement been? And the patient tells you, well, it has been once in 2 days. And immediately you prescribe, oh, okay, let me write a laxative. The patient is constipated. But constipation is a subjective feeling. It's most important to ask your patient, how different is it from your normal? So probably a normal bowel habit of this patient may be once in 2 days. So that's normal for him. Or probably that doesn't sound normal to you, but it's normal for him. So what is important is how different it is from their usual routine. And we do need to know that 45% of palliative care patients are constipated on admission. So, well, most of our patients in palliative care in general, when you talk about even the home care sectors of those patients who are visiting you in the hospitals, most of them have restricted mobility. They are probably spending about more than 50% of the time, or maybe 50% of the time in bed. And this itself can be one of the reasons. And also probably they're having compromised diet and so many other things. And maybe your patients are on certain drugs that is causing constipation. So we are going to see a lot of patients in palliative care who are having constipation. So what are the symptoms that the patient is going to come to you with? They may tell you that, yes, I do not feel satisfied. I feel incompletely I feel incomplete when I pass motion. Or they may say they feel very bloated, or the patient might present to you with nausea and vomiting, or maybe sometimes they're accompanied with pain. They just feel bloated, they feel a vague kind of pain, or they may have features of bowel obstruction. We will be going a little more deep into that in the following few slides. Okay. Or patient might be having something called as overflow diarrhea. Now, would you like to type in what is overflow diarrhea? Oh yes, thank you for those some responses. Manual removal, picosulfate, esophageal. Thank you so much for those responses. Yes. Did somebody say something? Okay. Yes. Bhavika says it's spurious diarrhea. Absolutely. Yes. And Sheila also agrees to that. It's constipation, which is followed by diarrhea, which we call as...
Ma'am, I would like to add.
Yes.
Yeah.
Thank
So
you.
there is technically a constipation episode, but
Yeah.
the diarrhea leaks from around this
Absolutely.
constipation once it is released. So that is called overflow diarrhea.
Absolutely. So that is exactly what overflow constipation is, and also agreeing to all those who had put it in the chat box. So when a patient comes to you with diarrhea, it is equally important to ask them when was the last time they had a normal bowel. Because retrospectively, they might tell you, oh, that was like almost a week back. And that is a very important history that you have got from that patient. Because what you're looking at is not just a normal diarrhea, but it is a spurious diarrhea or an overflow diarrhea, right? So for an overflow diarrhea or a spurious diarrhea, you need to treat it like a constipation. And again, as part of chronic constipation, okay, as part of sometimes even acute constipation, we do see urinary retention. This is so common, especially in the home care sectors. When you go to homes and you see patients, you get calls saying that the patient has not passed urine, the patient is having abdominal pain, and you go and you examine the patient, you see suprapubic tenderness and fullness, dullness on percussion with the bladder distended, and you know there is retention of urine. And then you try to probably put a Nell cath or a Foley's to drain the urine, and do a PR just to know that you are not missing out on one of the reasons for urinary retention. Especially if the patient family tells you that the patient is having constipation on and off. So that is very important. So what are the different causes for constipation? So we have medications, we have metabolic causes, we have diet, we have environment, we have neurological, we have other structural causes, something maybe anatomical reasons, which itself is obliterating the passage, which can cause constipation, and maybe even other reasons. So when it comes to palliative care, when we have to deal with so patients with pain, especially the opioids that we prescribe, sometimes step 3 analgesics, or maybe even analgesics like tramadol itself can sometimes cause constipation. Generally, drugs like morphine, the constipation caused by drugs like morphine is not self-limiting, and you will have to put your patients on laxatives for a very long time. Now, also antidepressants like the tricyclics, especially anticholinergics like buscopan, hyoscine butyl bromide. It also has an anti-secretory action. Anti-epileptics, anti-emetics. Yes, can you tell me an anti-emetic which causes constipation? Yeah. Can you tell me an anti-emetic which causes constipation? Yes. All of you agree it is ondansetron. Absolutely. All of you do agree to that. Yes, it's emicet or ondansetron, right? So it does cause constipation. Also, some antacids do cause constipation. And again, somatostatin analogs like octreotide, which is also an anti-secretory agent, can cause constipation. Now, metabolic causes, when the patient is having decreased bowel movements, it is very important to check also, or probably have a thought whether you are looking at an electrolyte imbalance like hypokalemia. And it could also be that the patient is simply dehydrated, or you could be looking at hypercalcemia. It is not so an uncommon presentation of hypercalcemia, right? And uremia. All these can present with constipation. And what about diet? Your patient is on different drugs. Probably your patient is on chemotherapy, lost all taste in his mouth, and probably having mucositis, unable to drink or eat. There's absolutely low fluids going in, and the fiber intake is less. That itself is a reason for constipation. And how about a patient who is probably staying with, like, 2 other people in the room? Nowadays, many hospitals have room sharing that is being done. So they have small like cubicles sometimes that they have to share the washroom, and whether their privacy is being addressed properly. Or maybe they are at home, and who is there to help them? Who is there to help them for the process? Like probably they have to be taken up and made to sit on a commode, or they have those portable ones, the chairs that can be taken to the washroom. So when they are not able to manage by themselves, they have to totally depend on somebody, and that itself sometimes can be reasons for chronic constipation. Of course, there are other pathological reasons like the malignant spinal cord compression or the tumors in the pelvis, or maybe as part of therapy, like say radiation, the radiation-induced fibrosis. All this can cause constipation. And many of the times, a very simple and common thing, patients are constipated, they have hard stools, and when they pass hard stools, there is some amount of excoriation that happens, and this itself, or probably they get a small anal tear, and this itself can induce a lot of pain in the anal area. And when the patient tries again to pass stools, when the anal orifice dilates, the pain is going to trigger again. So this itself prevents them from attempting to pass stools. So we need to address the pain, we need to address the local site issues as well as we are addressing the constipation. Now, there are also other reasons like depression, stress, anxiety, depression, weakness, immobility, sedation, or simply age. The elderlies, most of them have to depend on laxatives as years go by and as the mobility decreases. There is, depression is mostly associated with constipation, whereas in anxiety, we see mostly increased frequency of stools. Yes. So now that we know the causes, we see a patient who has come to you with complaints of constipation. You ask them the question, how different is it from the normal? And when was the last time you had a laxative? When was the last time you had a normal bubble? You ask them all the important questions like that. And that is why history taking is important. So the frequency, the amount, the consistency. Also asked for questions such as, is it blood-stained or not? And also, are they feeling any pain, nausea, vomiting, excessive gas passage, or fullness? And how regular they are with the laxatives. Now, let me tell you one thing. I'm sure most of you have had this problem with your patients. When patients come to me and they tell that, yeah, we tried laxatives, but it's not helping. He is very constipated, but, I tried giving laxatives, it is not helping. You ask them, when was it that, he was given laxatives? Well, last night. And when was it before that you gave the laxative? The previous night. So what would have happened is that they would not have passed stools for many, many days. And it is then only after that that they have started having the laxatives. When they are already on probably certain drugs that is known to cause constipation. So it is much better if they have especially had an experience of constipation related to the drug. It is always better to put them prophylactically on laxatives or advise them to take laxatives. Also, what happens is that patients mostly take laxatives only after like 4-5 days of constipation or 3 days of constipation. And what happens is that after they start passing stools, the latter part is more of liquid stools. And then they tend to have trickling of stools for the latter part of the day, which actually is very distressing for whoever it is. And this makes them refuse laxatives. So how you can avoid your patients from making that mistake is telling them the importance of prophylactic laxatives so that they are on regular laxatives and they can prevent this this from occurring. Okay. So what also asks what medications the patient is on. There could be n number of drugs which the patient is on, which is causing the constipation. So you can either try alternating those drugs, okay, or probably withhold the drugs if possible, only if possible, until the constipation is relieved. Okay. So is the constipation a recent change? That also you need to find out, and what type of diet the patient is on. Okay. Now, another common issue that we face when we go to see patients, or probably when we see them in the hospital, is they tell you, well, my mother has not eaten enough at all. So how is she going to pass motion? Is probably what a daughter tells about the mother who's been totally constipated. So this is what generally people think. Constipation is probably because they have not eaten enough. What we need to say is that, make them understand is that even if you have not eaten enough, there are secretions that is being produced in the intestines which can form stools. So it is important that he or she passes motion in a regular fashion. Okay. So also another thing that we have already discussed is I have diarrhea. So when the word comes diarrhea, always do not tune your mind into thinking that you are looking only at diarrhea. You should also think around it and try to rule out that the patient is not having an overflow diarrhea. Okay. So when you come to management of constipation, correct the correctable, like you go back to see if it is any of these causes here and check which of them can be corrected, right? So you correct the correctable and judicious use of laxatives. We have a whole lot of categories of laxatives. We are going to be getting into that in the next slide. So judicious use of laxatives. So if it has to be given 3 times a day, you have to give it 3 times a day. Generally, prophylactically, laxatives are given as bedtime doses, but so that they have a normal bowel in the morning. In case of constipated patients, you can always go for combination laxatives. You can always ask them to have it 3 times a day until they pass loose stools, and then stop it and take the laxative only from the following day bedtime if there is a persistent trigger which causes the constipation or any such cause which is not reversible, which is causing the constipation. Again, symptom control. Say suppose a patient is having very gaseous feeling, very nauseous feeling, or having vomiting. Try to control the symptom. If the patient has developed an anal fissure, try to control the pain. Advise the patient sitz baths. Advise the patient local applicants. So these are all different things that you can do to manage the symptoms of constipation. Okay. Encourage activity. Immobilization is also one of the reasons. So hence encourage activity and diet modifications. Those patients who are having colonic diseases, maybe high fiber diet, like say colonic cancers. Now, a high fiber diet may not be the choice for such patients. So, otherwise, in general, high fiber diet always helps to relieve constipation. Now, like we said in our previous class on nausea and vomiting management, always think about the non-pharmacological management as well. How was the accessibility of the patient to the toilet? Was he able to mobilize and go to the toilet? And how often is he able to go? Is he able to go when he feels the urge? Or does he actually have to sit and wait for the caretaker to come after work and only go in the evening. And the privacy, whether the room is being shared or whether there are enough barriers or curtains to draw. And the squatting, what is the position in which they sit. So all these things, and also the diet and how much fluid is being taken, all these things are important. So in management, you do a rectal examination. You can, what is most advisable yet not done in most of our clinical practice is a rectal examination. Okay, so a rectal examination is very important for those who have recurrent constipation, yeah, proper or refractory constipation, and also proper use of the right laxatives. You can also try suppositories. Also, let me tell you one thing. When suppositories are being advised and the family puts the suppositories, it is very important to tell them how the suppository has to be applied. What happens is that when the rectum is loaded and the suppository is applied by the family, they probably just push in the suppository. What you need to tell them is that how the suppository has to be in contact with the mucosal surface. Only then you get the desired action. Then enema, you can go for proctolysis, glycerin enema, warm saline enema, and preferably no soap water enema, digital evacuation for fecal mass which is impacted, right? And then moving on to what are the different type of laxatives. So like I said, there are different categories. You have bulk forming laxatives, you have lubricating laxatives, you have osmotic laxatives, stimulants, stool softeners. So bulk forming laxatives, you all know, like they will be high fiber laxatives, right, which help to increase the bulk of the stool and help in propelling the fecal mass. And again, you have lubricating like mineral oil, castor oil, or even glycerin. Then osmotic, where water is being drawn from the intestinal walls and hence helps to liquefy the stools and helps to relieve their constipation. And this is how milk of magnesia, PEG, and lactulose works. Movie call that. Then stimulant laxative like bisacodyl is yet very commonly used laxative by many of us. What we also need to know is that stimulant laxatives, it stimulates the peristalsis and helps to propel the stools forward. This can also cause some amount of pain and distress for patients. So it can differ from patient to patient, and for some, this is very distressing. So you need to ask how comfortable they were by when they use the laxative. Like many say that, please, I do not want laxative. Mostly because they were probably put on oral lactulose, and oral lactulose is very sweet. So they do not want that. So you need to know exactly what are the reasons when they refuse a laxative. And accordingly, you can check for alternatives. Stool softeners like decusate sodium are also very helpful. Apparently, it is a bit habit forming if it is, or they become dependent if it is used chronic uses. So few recommendations: paraplegic patients need regular stimulants and stool softeners. They may need initially a manual evacuation if there is severe constipation. And what about those with colostomies? Colostomies also can have constipation. Also, you may need to digitally evacuate fecal masses. Yes. And after obstruction is excluded, that is, you take out the impacted fecal mass, you can place in the suppository. So this is how it works. If it is soft stools, bisacodyl suppository. If it is hard stools, glycerin suppository. If you see an empty rectum, you do a rectal examination and you see an empty rectum, it is ballooned. which means that it's higher end. The fecal matter which is impacted is more in the higher end, at a higher level. So what you do is that you can give oral stimulant laxatives like bisacodyl, and at the same time you can give a high-end enema. How do you give a high-end enema? You have seen the pouch, the enema pouch. You attach a nail cap to it or a polish to it, and then slowly lubricate it and push the nail cap into the rectum and further above, and then you squeeze the enema pouch. So that way you get past the impacted fecal mass and reach the above, so that it can cause a local action at that area. Okay. Now, manual evacuation. So when you do a manual evacuation, it is very important that you give a proper explanation about the procedure and get an informed consent from the patient. Now, as you know, manual evacuation is not something which is comfortable for a patient. And at a point of time when the fecal mass is impacted and it is painful, doing a manual evacuation is going to definitely cause some increased amount of pain. So you need to use sufficient lubrication, preferably a local anesthetic jelly, local lidocaine, and give enough time for the local anesthetic to act, and gently and slowly you can do the procedure. Okay. And you can keep talking to the patient so the patient does not feel embarrassed and is comfortable. So if you take an X-ray of the abdomen, this is how it will be. You can actually see the impacted fecal masses in the X-ray abdomen. This is an erect X-ray abdomen that has been taken. So this is how you would see when it is a constipation. You see the dilated bowels, you see the impacted fecal mass. So what other finding would we see for someone who is totally not passing stools and you take an erect abdomen? Yes. Platus. You take an X-ray. I was asking about the X-ray finding. Yes. Multiple air fluid levels. Yes, thank you. Yes, we will be also seeing multiple air fluid levels if we are looking at something which we call as obstruction. If we are looking at a total obstruction or a subacute intestinal obstruction, when you take an erect abdominal X-ray, you are going to be seeing multiple air fluid levels. So luckily this guy here doesn't have multiple air fluid levels or anything. He just has dilated bowels with impacted fecal mass. Okay. Right, so this was the case history that we had in our previous class for vomiting, and we did say that this 54-year-old frail lady was having small, infrequent, incomplete bowel movements for 4 days and has been started on laxatives, and she is being accompanied by her younger daughter. So she is being admitted in the hospital, having incomplete bowel movements. She's on antibiotics and she is having vomiting and she is still constipated. And who is accompanying her? Your younger daughter. Okay. So what could be the issues that was leading to constipation in her? Yes. Chat box. So in that case scenario, what do you think was the reasons that she was having severe constipation? She was hospitalized, she was on antibiotics, she was on anti-emetics, she was accompanied by her younger daughter. Yes. Well, Hetal Kumar says it could be dehydration. She's vomiting, definitely. She could be dehydrated. Yeah. Azmi says it could be the anti-emetics. We did talk about ondansetron causing constipation. Well, Bhavika says it could be obstruction. Bharati says it could be a side effect of the chemo. Dr. Nibbin says it's the drugs. Maria also says it's the drugs. Hetal says it's probably the opioids that she is on, probably. We do not know. Then Sheila says it could be the poor intake. She's just vomiting, no proper food. Vivek and Junaid all says that it could be some electrolyte disturbance. She has been vomiting. It could have led to some electrolyte imbalance. Well, Preeti says it could be because she is not active. Sheila says it could be psychological stress. Well, Noble also says about the electrolyte imbalance. Dr. Subdeep also agrees to her. Maria says that it could be the caregiver is not giving enough help to her. It's a younger daughter with her, isn't it? Well, Roja also says that it could be a fistula, and all the psychological symptoms all could be pooling in, right? So now we know when we look at constipation. Thank you all for your response. It's been wonderful. So now we know that when we are looking at constipation, I mean, just look at the way you all are thinking. It is not just that you write a laxative, right? There are so many what could have led to her constipation. So definitely now, next time you see a constipation, you are going to think about what is reversible here. Are there any trigger drugs? Do you have to think about any alternative drugs so that you can relieve the constipation as well? And one important also way of treating constipation is adding in prokinetics. Prokinetics like metoclopramide can be given for the patient so that the patient has good bowel movement. Okay. So here, if the patient has been on ondansetron and that is causing the constipation, putting her on an alternative like metoclopramide is definitely going to relieve her vomiting. At the same time, it is going to promote bowel movements. Now, having said that, let us move on to intestinal obstruction. So we did talk about the X-ray, abdomen erect X-ray showing multiple air fluid levels. We are probably looking at an intestinal obstruction, right? Yes. So we are going to look in a little more deep into intestinal obstruction. Let us see what is the different classifications, what symptoms the patients present to us with. How do you diagnose intestinal obstruction? How are you going to manage intestinal obstruction in palliative care? So, how do you know? I mean, where is we know that intestinal obstruction can be anywhere, right? It can be in the small bowel, it can be in the large bowel, right? So, how do you think we can diagnose an intestinal obstruction? How do you think we can diagnose an intestinal obstruction? Chat box? Pain. Hetal Kumar says the site of pain, where it is. Well, Azmi says when they've not passed stools. Dr. Sudeep says the history. Hetal Kumar also says constipation. Prasanna says projectile vomiting. Yes, x-rays, vomiting, the pain. Nishant also says about pain. Failure to pass stools and gas. Tisha says so. And yes, we have all these different ways in which we can ask them. Yes, and Nishant also talks about bouts of vomiting. Okay, now what is it going to tell you? Dr. Chaitra talks about distension and absence of bowel sounds. Absolutely. Now, how are you going to know? Okay, now where is this obstruction? You are at the home of the patient and you are looking at this patient who is absolutely constipated for like about 6 days in severe abdominal pain. He's not able to tell you where the pain exactly is. He just has colicky pain, right? And you need to know, I mean, what exactly this patient is having. Where is the obstruction? Well, you did put in a lot of replies here saying doing a PR, probably the guarding and rigidity of the abdomen, or probably the hyperactive bowel sounds. Well, I have an answer here saying it's proximal obstruction. There is loose stool present initially. And Dr. Nishant also says by auscultation. Yeah, if it is a complete obstruction, you probably don't even have bowel sounds. Is there a way where we can know, is this a small bowel obstruction or is this a large bowel obstruction? You're at the patient's home. how can you say that is this a large bowel obstruction or is this a small bowel obstruction? Well, let's find out. So when I come to the different types of yes, I did get some answers here from Sangeeta and Tisha. They say large volume vomitus is seen in the small bowel obstruction. And Itisha says bilious vomiting is in the small bowel. Thank you so much. Yes, that's absolutely right. So intestinal obstruction, mainly it is of two kinds. You have the non-mechanical obstruction. You have the non-mechanical obstruction and mechanical obstruction. So non-mechanical obstruction, you don't exactly have something over there, right, which is causing the obstruction. It can be an adynamic bowel, and there is absence of the peristaltic contractions. And that is when you auscultate, you do not see any bowel sounds, right? Now you come to mechanical obstruction. Mechanical obstruction, again, it is further classified into acute, chronic, depending on the speed of onset, the site, being small bowel, large bowel, the nature, whether it is a simple one or a strangulated one, or etiology. Is it something where there is a mass sitting inside the lumen which is obstructing it, right? Or is it something which is within the wall which is obstructing it? Or is it something which is outside the intestinal wall which is obstructing it? So you have intrinsic, extrinsic, and intraluminal. Okay. So also you need to find out if you need to know if there is a single point of obstruction or there is multiple points of obstruction. Are you looking at a risk of perforation, or is it strangulated? So when it is strangulated, that is the blood supply is compromised. More or so like signs of mesenteric ischemia, pain is going to be severe. It's going to be more localized pain, and the patient could have even melena, vomiting, right? And maybe signs of fever. Now, what can be the other causes for mechanical obstruction? So you have intraluminal causes, you have intramural causes, or extramural causes. So say suppose someone has a lot of impacted some stones, right, or foreign bodies, it can cause obstruction, mechanical obstruction. Or say suppose it is a malignancy, it is a tumor which is seen in the intestinal wall. This can cause obstruction, or it could itself cause some stricture. Now strictures are also seen as part of previous surgeries, or it can be also seen as part of radiation, post radiation, like adhesions and bands, and also paralytic ileus can be other reasons. So why is there the symptom of pain, vomiting, and bowel distension in those who have obstruction? So when there is actually a partial or complete bowel obstruction, what happens is that there is colicky pain. Now, how does the colicky pain occur? You have an obstruction at this point, and you have the normal bowel movement, which happens like waves. So it is just one after the other wave coming one on top of the other, which in turn causes a lot of colic kind of pain. Okay. It is not able to surpass the point of obstruction. So there are bowel contractions which lead to the colicky pain. Now, this is not the only reason why the patient develops colicky pain. When there is an obstruction, there is decreased movement of intestinal contents. Now, when there is decreased movement of intestinal contents, obviously there is going to be distension of the bowel. And when there is a distension of the bowel, the surface area of the bowel gut wall is going to be increased, and there is increased secretions further coming in. And all this together can be reasons for nausea and vomiting when there is so much of increased secretions that is happening. And also when there is so much of distension that is happening, there is damage to the epithelium, okay, causing an inflammatory response, which itself causes a continuous pain like a vicious cycle. So the level of obstruction, like I said before, is it a small bowel obstruction? Is it a large bowel obstruction? That determines the pattern of symptoms. Like you all, like one of you, a few of you have been rightly telling it. If it is a small bowel obstruction, it can be a very large vomitus, large volume vomitus. It could be bilious. If it is a small bowel obstruction, that is a higher level of obstruction. If it is if it is a lower level of obstruction, a large bowel obstruction, it may be rather progressive and the abdominal distension is more. Now, if there is complete obstruction, you will not see your patient telling you that they are passing flatus or there will be no fecal mass, absolutely, or the patient could be having spurious diarrhea. And even when you auscultate, you may hardly hear any bowel sounds. So what you do is you decide to take a erect abdominal X-ray, which is like the simplest investigation you can do to diagnose an intestinal obstruction. And this is what we see, multiple air fluid levels. And that is pretty diagnostic of obstruction. So now that we have found out the patient is having obstruction, we need to know what to do. So the patient presents to you with symptoms of bowel and obstruction, and you do a good clinical assessment, you take a clinical history, and you do necessary radiological investigations, and you understand, okay, this patient has a small bowel obstruction. Or you understand, okay, this patient has a large bowel obstruction. Okay, so now what do you do? And you understand that the patient is having a malignant bowel obstruction. So there are these factors with which you decide what next, being factors like patient factors or being factors like disease factors. So patient factors would be, what is the age of the patient? Now, when I say what is the age of the patient, it does not mean that if your patient is 70-year-old, treat them conservatively. If your patient is 35-year-old, take them for a surgery. It doesn't mean that. Age is a number when it comes to most of the chronic diseases. It totally depends on the performance status of the patient, right? So you may have a 70-year-old or an 80-year-old gentleman who is absolutely fine with a performance status of 1 or 0. So you need to consider the performance status rather, and also the stage of the cancer. If it is an advanced ovarian tumor post multiple lines of chemotherapy, you are having an advanced stage of the disease which is carrying a poor prognosis. So the stage of the cancer of the patient, any further anti-cancer treatment options, whether has it been discussed with the patient, or how malnourished is this patient, whether the patient is absolutely malnourished, cachexic, or any other concurrent illness. There is no point in planning a colostomy for a patient with obstruction, with malignant bowel obstruction, if he or she is having a end-stage renal failure. So the comorbidities also play a huge role. Now, coming to the disease factors, it depends on the extent of obstruction. Is it just that one level of obstruction that you do a resection and anastomosis or or colostomy? Or is it multiple levels, whether your surgery is actually going to have any benefit at all? And the site, whether it is a proximal or a distal bowel, whether it is functional or mechanical. So it's going to be futile if it is a functional bowel, right? So again, if the patient has ascites, it is difficult to think of a surgical intervention right away. Carcinomatosis peritronii carries a poor prognosis. So that also will have to be managed conservatively. So accordingly, we plan for the patient what has to be done next. So this is an algorithm which will help you decide how to channelize your patients when they are diagnosed with bowel obstruction. So those patients who have to be managed conservatively, who carry a poor prognosis for surgical intervention, are those with advanced age of cachexia, who have a widespread tumor or probably deranged metabolic parameters, who has ascites, low serum albumin, severe nutritional deficiency, large abdominal palpable masses, previous radiotherapy to the abdomen pelvis. The abdomen is going to have a lot of adhesions and strictures. Now, history of combination chemotherapy, what I meant over here is multiple lines of chemotherapy, which would suggest that the patient is having a poor prognosis, multiple lines of obstruction, poor peristalsis because of carcinoma peritronii, and poor performance status. So all these are factors which tell you this patient is going to have a poor surgical prognosis, poor prognosis on surgical management, and henceforth has to be managed conservatively. So how do you treat such patients? Pharmacological treatment. We just learned how to treat constipation, right? We used laxatives. Now here we are using corticosteroids. Now again, why are we using corticosteroids for malignant bowel obstruction? Yes. Corticosteroids, yes. Dr. Pooja, Malavika, Vivek, Bhavika, Jyoti, Roja, all of you agree to the fact, Dr. H.K. Das, all of you agree to the fact that we start the patient on corticosteroids to decrease the peritumorality, right? So even Dr. Nibbin agrees to that. And definitely it helps to decrease the peritumoral edema. So what we usually give is injection dexamethasone, and generally in practice I give about 16 milligram to 24 milligram IV OD once daily, and I try to avoid the night dose because it may interfere with the patient's sleep. So generally it is given before 6 p.m. anytime before 6 p.m. And antiemetics, definitely because the patient is having vomiting. Now again, you may have patients who are having severe pain, colicky pain, and also vomiting. So you may tend to write an antispasmodic like Buscopan. You may tend to write an antispasmodic like Buscopan, which is hyoscine butyl bromide. But as you see a patient having vomiting, you might think that ondansetron causes constipation. So why not I write metoclopramide? But you need to know that do not combine Buscopan and metoclopramide or perinomide because they tend to cancel each other, right? So you can prescribe antiemetics like haloperidol or Ondim, okay, as you step up your laxatives, all right? And if your patient is in pain, colicky pain, you can go ahead with Buscopan, right? It also helps to bring down the secretions and bring down the vomiting. That is the same reason why we also prefer for somatostatin analogs and definitely analgesics according to the pain scope. Now, also you can treat your patients surgically by resection of the bowel segment. It is expert care. We can refer the patients, is what I meant. We can refer the patients for surgical treatment by resection of the bowel segment, colectomy, ileostomy, colostomy. Now, ileostomies are difficult to maintain for the patient because there is very frequent secretions, larger amount of secretion, larger volume of secretions in ileostomy. Invasive procedures, nasogastric tube insertion. So when patients come to you with malignant bowel obstruction, patients have a distended abdomen, they are having vomiting, they are not able to take anything intake, they are not able to take anything as diet or liquid. So these patients are generally put on nasogastric tube. You must have seen. So this is to decompress the bowels. So what is done is that you put the patients on NG tube, and at the same time, this does not mean in palliative care, we always tell our patients, this does not mean that you do not take even sips of fluid. You can take sips of fluid according to how much you can tolerate. So if the patient is on NG tube insertion and is taking sip of fluids, not vomiting, well and good, take sip of fluids, right? So again, other ways, you have gastrostomy for feeding and also colonic stent in case there is a luminal narrowing and you would like to stent. Now these invasive procedures like applying stent is advised for patients with a longer survival. Okay. So coming to antiemetics, we have metoclopramide, a dopamine antagonist. Start with 10 milligram 8 hourly, IV or subcutaneously. Gradually increase the dose day by day. I mean, on a day-by-day basis, if needed. Okay. Now we also have 5-HT3 antagonist and prokinetic, which is given only in partial obstruction. If there is a complete obstruction, prokinetics may not help. So if you think it is a subacute intestinal obstruction, you can definitely go for prokinetics. Okay. And haloperidol for nausea vomiting is another antiemetic that you can use. So like I said before, anticholinergics will help to bring down the pain and it can help to bring down the secretions, which will in turn help to bring down the vomiting as well, right? So you have Buscopan, which you can also have other options like scopolamine, right? And what you need to understand is, excuse me, give me a second. Yes. Well, we also have other options like scopolamine. And what we need to know, like I said before, it cannot be combined with prokinetics, right? Well, I did talk about corticosteroids. Yes, dexamethasone is the drug of choice, and try to not to give it in the late evening. And what we do here is that we give it for 3 days as a trial. We check for bowel sounds. We check. We ask the patient if the patient has started passing flatus. Yes, and that shows that the corticosteroid is working. And if it is working and you're managing the patient conservatively, you can bring down the dose of the steroids. And what I usually do is that I taper the patient on steroids and I stop it. If vomiting subsides, continue oral steroids. Okay. And steroids act by reducing the peritumoral edema. Now, somatostatin analogs, well, octreotide is an expensive option than Buscopan, but very useful. 100 micrograms subcutaneous per day can be given. So medical management of a malignant bowel obstruction in a nutshell would be something like dexamethasone, 8 to 16 milligrams subcutaneous. Well, I did talk about 16 milligram at least that has to be given. So 8 milligram may be a little low for a patient. I would say maintenance would be something like 8 milligram, right? And if you want to manage on a 3-day trial, it should be as high as 16 milligram. So metoclopramide is yet another drug, and hyoscine butyl bromide or haloperidol. Okay, so this is basically how it goes, and this is how your prescription will be looking. So this is just a picturization showing how the stent is applied into the lumen, self-expandable stent, and it helps to relieve the obstruction. Now the common frequently asked questions about hydration. Your patient who is on malignant bowel obstruction and is put on IV fluids, or the family tells you, let's put the patient on IV fluids throughout 24/7. And what is your answer? You're looking at an advanced stage of cancer, and the patient is having a malignant bowel obstruction, having severe vomiting, right? And is in the terminal phase, also having, respiratory secretions. So this patient is in distress, and the family is like, obviously the patient is not able to eat anything at this point. So let's hydrate him. Let's put him on fluids round the clock. Well, TPN is the best. They say that TPN would be the choice of the recommended choice only if the patient has more than 3 weeks of prognosis. Yeah. So, well, hydration, well, most of you do say that, IV fluids is a no over here. I mean, you do say, I do see a lot of answers here. Exactly. So, like you all say, IV fluids itself could add on to the secretions in the form of vomiting. It could add on to the secretions in terms of the respiratory secretions and distress. So, we need to actually be very careful with the hydration of the patient. Like I said before, sips of fluid is always very comforting for the patient who is nil oral. So oral feeds, according to how much the patient tolerates, is the answer. If he is able to tolerate liquid feeds and yet not vomiting, well and good. Give them liquid feeds. Okay. TPN, like I said, it has to be, you go by the prognosis of the patient and decide. And again, an NG tube or a gastrostomy for feeding, it all depends again on the prognosis of the patient. Well, we do have answers over here, like fluid replacement is less in end of life, so may not be required, absolutely. Overhydration may lead to acute kidney injury, so slow, gradual correction will be helpful. Thank you. And we do have here a comment, Dr. Vineeṭha, what may be the line of treatment option for the patient from the palliative care point of view? Yes, you were talking about the patient over here. Was it in the beginning? Was it in the beginning?
No, it is in the mid.
Sorry?
It is in the mid portion of the slides. A few slides from this. Previous, another 5 slides beyond it.
Wait a minute. No.
Yeah. Once again, go.
Okay, so this?
No. You have just shown the slide. Yes, yes.
Oh, not eaten enough. Is that what it was?
Another 2 slides from.
We've done with the slides. This was a case scenario that I had put.
Yes.
And yes, were you asking about this in a palliative care point of view?
Because
Okay, well, if you're able to come back on that later, I would definitely be very happy to answer that. Yeah, so now we move on to another case scenario. Okay, so Sarah is a widower and she's supported by her children who are living in the UK. Okay, so she's pretty much alone over here. And like you see that her spouse is not there. So We do not know who's taking care of her. Anyways, it is someone who does not have decision-making capability for her. So Sarah is 62 years old. She was diagnosed with CA stomach, stage 4, right? With mets to the peritoneum and anterior abdominal wall. And she had a palliative distal gastrectomy followed by chemotherapy. But what happened is unfortunate for her that after 2 cycles of chemo, her disease started to progress. So she developed vomiting and abdominal colic for 2 days, but was still able to pass small amount of stools daily. She's been having vomiting 3 to 4 episodes per day, which is unrelated to meals. And the vomitus was bilious and partially digested food. And her abdomen was not distended. She was not dehydrated. Bowel sounds were sluggish, right? Palpable nodules were seen on the abdominal wall, which were mildly tender. Now, when you look at this, what do you think we are looking at? She's been having multiple episodes of vomiting, and she is passing small amount of stools. Yes, her abdomen is not distended. Yes, we are looking at obstruction. Absolutely, Hetal Kumar also agrees to that. We are looking at small bowel obstruction. Yes, Bhavika, Nishant, Jyoti, Prasanna, all of you are absolutely right. We're looking at partial small bowel intestinal obstruction. Yes, Junaid also agrees to that. Preetak also agrees to that. It's subacute intestinal obstruction. To be precise, we're looking at small bowel obstruction, right? We did not even need a CT over here to understand that. Right. So in view of the persistent vomiting, a nasogastric tube was inserted. Sarah was told that the nasogastric tube insertion would be a temporary measure for decompression. Now a CT scan was taken and it is a small bowel obstruction. As she is still opening her bowels, the impression was that it's a partial bowel obstruction. So what did they do? They gave her a suppository, bisacodyl, and regular interval intravenous metoclopramide, okay, because she was anyway still passing bowel. So a prokinetic like metoclopramide would help. She was not having any pain, so we were not giving any antispasmodic to counter that. So that's good. Intravenous dexamethasone, 8 milligram per day. It's a little suboptimal dose, okay. And she was also started on fentanyl infusion, 10 microgram per hour for worsening of nociceptive lower abdominal pain from the peritoneal mets that has been present for the past 2 months. Okay, so she was having a nociceptive pain there. Okay, that is from the abdominal wall. It was not a colicky pain. Okay, now what happens? Now what happens is that there is no bowel action and the intravenous metoclopramide was increased to 60 milligram per day. Earlier it was 10 milligram every 8th hourly, right? So she was getting 30 milligram per day. Now it has become 60 milligram per day on the following day. Now this gives a good clinical improvement and the NG aspirate has reduced significantly and she has no more vomiting. So what happens? The doctor comes, pulls out her tube and starts her on oral feed gradually. And IV metoclopramide and dexamethasone were given for 2 days and stopped. 3 days later, she starts vomiting again. Now, she had 3 episodes of vomiting in a day, which was moderate to large bilious vomitus. Again, it is that small bowel obstruction there, right? And she was recommended again metoclopramide, dexamethasone, and in addition, intravenous ranitidine was added to reduce the gut secretions also. Okay, so with that, the vomiting subsided. But what went wrong here? What is it that went wrong? I mean, she was started on metoclopramide, she was started on dexamethasone, all that was good. And then what happened? She was just good for a day or 2 and then 3 days, bang, it starts again. So how would you modify that prescription? Maria was asking about constipation. Okay. Nishant was saying maybe it is the early removal of the NG tube. Well, Deepak says that we should have tapered the steroids. And Sheila also says the perinom should not have been stopped. And Dr. H.K. Das also says that definitely it was the sudden withdrawal of dexamethasone. Yes, all of you agree, Bhavika, Deepak, all of you agree that it was the medications that was stopped immediately that led to the reoccurrence of the symptoms. All right. So here we need to understand in such situations, yes, they were on parenteral medications. So what you ought to do is that once the symptoms subside, and after 72 hours, it is better to change it to oral. And after changing it to oral and preserving the dose of that oral medications given etavali, you bring down, you taper it over a longer period of time. So the goals of care were established after discussing with the patient and her family. And Sarah preferred to keep the nasogastric tube for decompression, while she could also enjoy taking fluid orally. So the decision was made to stop further chemotherapy and proceed only for comfort care. So she returned home with home hospice support. Well, that was the case of Sarah, right? And well, yes, Dr. H.K. Das says that he does feel that the role of palliative care is missing here, or, you know, needs to fill the gap. Absolutely. We do see that the goals of care was discussed much later for this patient, most probably because the children were not around and, you know, they were at a distance. They were just trying to support her with the information that was being given by the caretaker. And it was only finally when she went through all this that, you know, they finally sat down and they could make meaningful decisions on what to plan next. So bowel irrigation is something very important that we have to tell all our patients about who have a colostomy, so that they can time their bowels regularly in the morning. These are the different parts of the bowel irrigation process, right? So this is how the bowel irrigation is being done. Every day in the morning, the patient is asked to irrigate his bowels, right? Like you can see there, it has a small conical like tip that is in the irrigation bag. It is filled with lukewarm water and it is fit into the stoma, right? And after it is run through the sleeve, the irrigation sleeve, as you can see, irrigation sleeve is fit into the stoma and led to run down. Okay, sorry, and led to run down. So all the fecal mass, all the fecal material, it all just passes down the sleeve into the commode. So if this is practiced by the patient every day in the morning hours for 21 days continuously, what happens is that the bowels get used to it. It becomes habitual for the bowels to open up only during that particular time. And these people can get back to work happen. Okay? So we've had a lot of professionals who have had colostomy and they just refuse to go to work just because they had a colostomy, even after their active treatment was done. So this is something which can help them. So this is all that we have covered today, right? And thank you. So I think we have also a case discussion for today. Probably we can have any other discussion after the case is being discussed.
Okay. Dr. Mohan?
Okay.
Yeah, I'm here. Okay.
Okay, I'm sharing the screen. Thanks.
Thank you. So, good evening, all. Myself, Dr. Nibin, so working as a junior consultant in radiation oncology, District Hospital, Kollam, Kerala. So, this is regarding a case presented to our casualty a few weeks back. It's a 67-year-old female. It's a case of carcinoma pancreas, stage 3, post-Whipple surgery. She's on chemotherapy. And her presenting complaints were inability to pass stool for last 3 days and abdominal discomfort in the form of a bloating sensation and nausea for last 3 days. Then history of illness, a case of pancreatic carcinoma detected 2 months back. After necessary evaluation, they proceeded with a Whipple surgery, and post-surgery, she was planned for adjuvant chemotherapy with gemcitabine and capecitabine for 6 cycles. She received 2 cycles of chemotherapy, and this is her 3rd cycle. So she received it 4 days back. And last 2 times she had constipation, even though drugs were already prescribed. The first time it is relieved only after enema. And last time it is not even relieved with enema, it's needed a manual digital evacuation. And the same time also, this time also the same issues. So on examination, she was conscious oriented. General examination was okay. Vitals were stable, and per abdomen distended. No visible peristalsis or pulsations. No organomegaly. Bowel sounds were present, and pulse rate. Per rectal examination shows hard stools, rotary in the rectum. So this is the investigations that CBC RFT and LFT within normal limits. Then serum electrolytes within normal limits, and X-ray erect abdomen that is not within normal limits. That no features of intestinal obstruction. There were no air fluid levels, but gas shadows was there. And USG abdomen also shows gas shadows, no specific mass, and they're planning for a CT abdomen. She's already received biscodile tablets, syrup lactulose, syrup cremafin plus etc. And she received a soap and water enema also. Then when I got the call, they're planning for a proctoclysis enema. So the psychosocial aspects, she's really anxious about the manual evacuation. Last time it was a stressful experience. And she's already accepted that she's having cancer and needs chemotherapy. And again, why this happening to me in the form of constipation? That's her main concern. Then husband died 1 year back. She's staying with her only daughter and having a feeling that making her life also difficult. Really worried regarding further cycles of chemotherapy and the frequent hospital attention and financial issues. And totally, she's in a stressful situation. So these are the medications. She received gemcitabine 1600 milligram IV 4 days back, and on tab capecitabine 500 milligram 2 BD. And she's on tab ondansetron 8 milligram 1 BD, tab ranitidine 150 milligram 1 BD, and neurobion fort, and then tab dulcolax 2 HS and syrup cremafin plus 30 ml HS. So main concerns are constipation and the reasons for constipations, frequent hospital admissions, procedure to relieve this constipation, especially regarding the digital evacuation, and adherence to chemotherapy. There are financial concerns, feeling that whether she is becoming a burden to her doctor. So summary, 60-year-old lady with carcinoma pancreas, post-Whipple surgery on chemotherapy, suffering from recurrent episodes of constipation following chemotherapy, not relieving with usual medications, and worried about the procedures and having psychosocial issues. So discussion points are components of her suffering, solution for recurrent constipation, and how to proceed. Does she need palliative care, and when and where to intervene?
Thank you, Nitin, for that presentation. And it's a very nice case, and we are able to actually pull out a lot of things from that case. So the discussion points over here for today, for all of us, is we have seen how this patient with carcinoma pancreas, after her surgery, she's put on chemotherapy, and how unfortunate that, it is the post chemo events, that is constipation, how it was not managed adequately, which is now making her feel as if, she has no idea how she is going to complete her treatment, and making her feel so hopeless, right? So what are the components of her suffering? So what do you all want to say about that? What are her components of suffering? Yes, we can use the chat box here. So what do you think is the components of her suffering? The different dimensions of her symptoms: physical, psychological, social. Yes, definitely. So what did you want to say? DMZ, can we?
Dexamethasone.
Okay. All right. Yeah. Right. Yes, we all know that all the dimensions of her symptoms are very much palpable here, and also the burden to her daughter, and all these multiple issues, definitely. And the constipation is not just the constipation, which is a physical problem that the patient has. And Dr. Chaitya also did talk about the economical, the financial burden that the patient is worried about how the family is going to manage now that the husband is also not there. There's only the daughter that is there, right? And she will definitely, yes, like Prasanna was saying, she'll definitely need a good palliative care team to take her through this journey. A good counseling is what Asra says. And colostomy is another option, is what Dr. H. Kedar says. So let us see what went wrong here, right? Solution for the recurrent constipation. So when we know that this is a recurrent constipation that the patient is having, the patient is on 2 drugs of chemotherapy. Okay, now gemcitabine is one drug, capecitabine is another drug. Gemcitabine as such, just like many other drugs, does cause constipation. Well, capecitabine has a risky side effect, I would say, of having loose stools. So the patient initially probably had to be on vigil whether the patient is having loose stools for capecitabine. And what we did see for the previous cycles is that the patient was developing severe constipation, which was difficult to be relieved. So what needs to be done is that the patient has to be on prophylactic laxatives. Ask the patient to take the laxatives from the day of the chemotherapy, from day 1. And it is very subjective. Constipation is very subjective, right? So, and it differs from person to person, right? So if the patient is taking HS dose of Dulcolax and HS dose of Crimafin, it is very important to tell them that if the patient is taking only HS dose and still not passing stools, please repeat the dose in the morning. There are so many people taking laxatives, combination laxatives as such, multiple times in a day, say at least 3 times in a day, because that is what suits them. So the patient will alone be able to decide what is the right dose for them in order to get a normal bowel every day. So that is one reason which has to be looked into. And if the patient is having good bowel sounds and things like that, we are not thinking of any other obstruction, okay? And also not having any other features of obstruction on or adynamic bowel or things like that, no electrolyte disturbances, right? That also is not there. X-ray abdomen was also normal. We are not looking at a malignant bowel obstruction. So it is purely constipation. And why constipation? Constipation because she is probably under a lot of stress. It is the daughter who has to help her. Probably privacy factors are there. The environment. Maybe the daughter goes to college and comes back only in the evening to help her, take her to the washroom. Yes, Dr. Chaitra was asking about the potassium levels. He did say that the potassium levels were within normal limits. Yeah. So we have ruled out hypokalemia induced. We have ruled out hypokalemia induced obstruction as well, right? So how do we proceed? How do we proceed? So that's exactly like what I said. I suggest that the patient should be on prophylactic laxatives, and this is how we tell them: if HS doesn't work, try BD. If BD doesn't work, try TID, or change the laxative. Change the laxative. Go for docusate sodium to soften the stools, or docusate sodium to soften the stools if stimulants are not working. And you can also add something little more aggressive like picosulfate or PEG. Okay. And yes, like you rightly said, the anticipation that, oh, will I be able to pass stools? Will I be able to pass stools? Non-pharmacological management of constipation. Let the water running. Give some distractions. Maybe read something during that time. These are all different things that you can tell the patient in order, to relieve constipation non-pharmacological way. right? And does she need palliative care?
Definitely.
Does she need palliative care?
Definitely.
Definitely, absolutely. She definitely needs palliative care because she has to be treated as an individual, as a whole. It is not just her symptom, that is just the constipation that has to be managed, but as a whole, addressing her physical symptom, that is constipation, psychological symptom of having to go through the disease single-handedly with the help of her daughter, who still has to look into her own things, right? And the mother also has to partially look into the daughter's life. Okay, the economical reasons, the financial issues, the spiritual issues. Why me? Why do I have to go through this? I had cancer. I went through chemo. I went through surgery. I went through chemo. Now, why am I still having side effects which are just going on troubling me? Okay, so this is where we have now come to. Yes, intervention starts once she reports to the clinic or OPD. And if she is under a good palliative care team, we would have a home care team which visits her at her home, and then we exactly know what is actually troubling her. Because many of the time when the patient comes to you, into your clinic, into the OPD, they come with a particular frame. Okay, you will never be able to guess most of the time until you sit down and talk to them what their issues are. When you go to their houses and you start talking to them, a lot of things fall in place and you know exactly where to intervene. Right. So open for discussion. Another 2 minutes. Yes, anything that anybody would like to add in or probably even suggest? We all are practicing, we all are dealing with patients with constipation and multiple related issues. So if anybody would like to put in any suggestions, always welcome. This is an open platform. Yes, definitely. It was very interactive. I was loving each and every moment of it. Yes, Dr. Niben asked which all drugs and dosage of drugs for this patient. I would suggest that the patient is put on good prokinetics, right? So if the patient is put on any post-chemo medications, I would put the patient on a combination prokinetic and PPI. Say, I usually put the patient on rabeprazole, domperidone combination so that that also helps the patient, and also Dulcolax, Dulcolax 2Hs or BD can be given, and Crimafin also can be tried the same way. Well, these doses are already been taken by the patient, so that can be, the frequency just has to be increased, is what I would say. And yes, if there is any anti-secretory drugs, probably this patient had some pain or something, abdominal pain, someone has put the patient on buscopan, things like that. So that also has to be looked into. Where the patient is depressed, what if the patient has been put on amitriptyline? That itself can cause. So look at things like that, right? And what about the diet of the patient? What if the patient is taking only solid diets, not enough fluids? That also has to be looked into, okay? And any anal fissures, the patient is having recurrent constipation. Ask the patient, is it painful while defecating? So address that, right? And in total obstruction, which antiemetic would be the best? I would say in total obstruction, definitely we can go for things like Serenase, haloperidol. Haloperidol and ondansetron also will be very helpful. Yeah. And yes, Prasanna says that this patient will require indoor palliative care and a holistic approach, as she will not be able to come to the OPD frequently as she stays alone. Yes, absolutely. We definitely need a home care support for this patient. Only then we will be able to address all the symptoms that the patient has. I mean, all the dimension of the symptom that the patient has. Yes, it's 6:30. Time's up.
Okay, and to add on, there was some mention during the question about drugs which might be causing antibiotics which might be causing constipation. There was mentioning about metoclopramide and domperidone. Some of the conditions as mentioned as metoclopramide and domperidone.
Yeah, you were asking question?
Sorry. No, ma'am, I just want to bring it to your attention that when you ask the question, sorry,
Okay.
drugs causing constipation.
Oh, okay. There was that. Okay. Well, I guess now that is clear.
Yes. So, if there is
I
anything
guess-
more to clarify, shall we wind up the session, ma'am?
Yes, sure, definitely. So thank you very much, everybody.
Thank you,
Thank you,
ma'am. Thank
Pallium.
you very much.
Thank you, Dr. Arjun.
Thank you, Dr. Vineeṭha, for joining us and enlightening us on a very crucial topic for the 2 days. Thank you so much. And thank you all the participants for making the session interactive. And with the promise that we'll be meeting again in the next session with another eminent faculty and another important topic. This is Sripriya, along with Dr. Vineeṭha Rijju and Dr. Arjun Devarajan signing off from the Tips Eco Hub. See you in the next session, everyone. Till then, take care. Bye-bye.